Good afternoon, everybody, and welcome to today's meeting of the West Yorkshire Health and Care Partnership Board. My name's Tim Swift. I'm a councillor in Calderdale. It's my pleasure to chair this board meeting. And today, in our discussions about the way in which we work together on services and support for people in West Yorkshire, the main items on the agenda include an update from Rob Webster, our CEO lead, reports on our ambitions to reduce sometimes you just know you shouldn't start on a word, don't you? To reduce antimicrobial resistant infections, an update on our ambition to tackle climate change, some work on health and housing, and an update on the Mayor's West Yorkshire Local Transport Plan strategy. Rob's report on the agenda covers a number of changes to personnel, but I do particularly want to welcome Nadra Mazir to the meeting. Nadra has taken over as the acting chair of the Integrated Care Board following Kathy's new role, and also as the vice chair of this partnership. So welcome. You'll see as we go through that we've taken a different approach today to the patient and public voice items. Instead of having them as a separate standalone item, we've embedded some patient and public voices into several of the items on the agenda, and I hope people find that approach helpful. I could just remind everyone, we've done lots of these online meetings, but if people can mute their microphones when they're not presenting or speaking. When you are speaking, if possible, if you can have your camera on, and please use the raise hand function or the chat function, but preferably the raise hand function to let me know when you want to contribute. The second item we've provided for is time for questions and public deputations. We haven't actually received any questions or public deputation requests for today. We do welcome them, though, as one of the ways in which we can demonstrate our commitment to openness and transparency. Item 3 is to remind members of the importance of taking conflicts of interest seriously. All of those of us present will be abiding by the rules and policies of our own organisations, and there are registers in place for that, but we also bring together a composite register. So if people do have specific interest to declare in any item on the agenda, I think it's probably best to do that on those specific items when we get there, but we'll make sure it's properly recorded and minuting. Item 4 is the minutes of the previous meeting, and I'd like to first of all ask if anybody has any questions, comments or points of accuracy on the previous minutes. I'm not seeing any hands, so in that case I'm going to take it that we can approve those as a correct record. And Ian, can I just ask you to update us on the couple of actions that are noted?
Yeah, thanks, Councillor Swift. So both of the actions are closed as per the notes from last time. I would like to bring in Fatma Khan Shah, the Inclusivity Champion, to just provide a bit more of an update in relation to the work that's been done across the system on the equality and fairness strategy and where we might take this next. So I'll hand over to Fatma if that's okay.
Thanks, Ian. Thanks, Chair. Good afternoon, everyone. My name is Fatma Khan Shah and I'm proud to be the West Yorkshire Inclusivity Champion. And just for the benefit of colleagues who are new to the meeting, we presented our equity and fairness strategy in December last year, which had a number of strategic objectives or actions for collective working within the partnership. One of the things that we've been working on since then are the contributions of organisations sharing with us how they're responding to those 10 strategic objectives, and those include examples related to inclusive recruitment, anti-racism and improved data collection. We're still working through some of the actions with some partners, but we're proposing a couple of things for the partnership board to support, Chair, if I may. The first thing is some consideration consideration of how we will continue to report into the Partnership Board, particularly in light of the changes of the architecture and future ways of working. And the second one is a proposition to ensure that we maintain momentum on this in recognition of some of the new areas that we adopted, such as mortality, end-of-life care, and also maternity. So our proposal would be to consider maybe a twice yearly update to the Partnership Board, but that is obviously dependent on what the board considers to be a future way forward. Thank you.
Thanks very much, Fatima. And just see if there's any comments or views on that. I mean, I think both of those are sensible and important, but as you say, it's very much about building into the wider discussion about the future of our partnership work and how we structure those things. So we will pick those up and take that forward in that discussion, if that's okay. Okay, thank you, everybody. So that brings us on then to item 5, which is our update from Rob. So I'll hand over to you, Rob.
Thanks, Chair. Hello, everybody. My name is Rob. I'm the Chief Exec of NHS West Yorkshire and the Lead Chief Executive for the Partnership. So you've got a fairly substantial report in front of you, which covers a lot of ground. And I'll just emphasise a couple of points and bring in anything that's happened since the report was circulated a week ago. And I'll probably start with something new, actually, which is the unwelcome news that the British Medical Association has canvassed its members of resident doctors, formerly known as junior doctors, and they have received a mandate to move to industrial action. And that as things stand at the moment, we're planning for handling a resident doctors strike starting a week on Friday. And that will be something which we will work collectively to minimise the impact of for patients, people and citizens across West Yorkshire. Talks are due to happen before the planned date of the strikes, and we're hoping that there'll be some sense of agreement between the two parties, between the government and the British Medical Association. We've spoken previously about the fact that we've successfully managed to ensure that urgent emergency care was available during previous strikes, and that we've minimised the amount of cancellations of things like elective care, whilst also recognising that this sort of disruption, it has to be managed, and therefore people managing it aren't doing other work, which might be about improving quality or outcomes for people. That people on the end of cancellations could face distress, concern, and ultimately harm, particularly if it's repeated, and that we would want to avoid those things if at all possible. So we're hoping for a national resolution to those issues and recognise that there are things that we need to do to make sure that all of our staff, including resident doctors, feel supported and appreciated in the organisations within which they work and within this system. So that's the first thing, which isn't in the paper, which we just wanted to update the partnership on. In terms of the report itself, you can see that it really focuses on some significant policy changes, which bring significant opportunities for us. Some issues around operational delivery and then organisational form. And it's worth just emphasising a few points from those. I think in terms of operational delivery, one of the things that we continue to ensure that we engage in as a partnership is the safe and effective delivery of care. And in that safe and effective delivery of care, improving the outcomes as far as we can for people. You'll see that in the further reports on this agenda today. Nationally, maternity and neonatal care has been in the news significantly, and the Secretary of State has announced an investigation into the state of maternity care across the NHS, with a significant focus on 10 organisations which are yet to be named. And that is anticipated to consider where improvements can be made and where good practice is operating so that we can improve care across the nation. We haven't had any confirmation yet whether Bradford is an organisation that's recognised as outstanding according to the CQC, or other organisations which have been in the news are part of this at all or not. So we don't know if any West Yorkshire organisations are involved. They may be. That kind of focus on safety and delivery is also the theme of the chair of NHS England's review into quality and safety across the health and care landscape. So there's quite a detailed section in my report which describes the findings from that review, which are looking to simplify and streamline the arrangements around quality and safety, and to ensure that the effectiveness of services, the outcomes of services, the experience of people receiving services are given significantly more weight alongside safety in the future, so that we have a high quality health and care service. You'll see from Dr. Dash's report that there's some important things which will be of relevance to the partnership. So the idea that there should be greater focus on allocation of money to improve outcomes for people. The focus on a care quality commission which is effective and considering all elements of quality in all parts of the system, and the streamlining of public voice. So Healthwatch partners on the call and others will be aware that significant impact upon Healthwatch with the 10-year plan, which is covered later in my report, confirming that National Healthwatch will be dissolved and local Healthwatches will be dissolved too, with the responsibility for public voice moving to local organisations. At this juncture, I will put on record my personal thanks and hope the partnership will put their thanks on the record for our local Healthwatches, which have done brilliant work as a member of this board, as a member of the board of the ICB, and in creating significant amounts of intelligence and input that have gone into decision making and service developments in all 5 of our places. So thank you to Healthwatch staff. The changes some of the changes will require legislation, others won't. So we'll see what the delivery plan says about the timeline for those changes. You'll see there are other regulatory changes in Dr. Dash's review, which, as I said, aim to simplify the landscape and the proliferation of organisations which are checking quality in the health and care space. The key thing for us as a partnership, I think, will be to make sure that that streamlined set of arrangements we work well with and they work well with us, and we don't lose some of the positive elements that we enjoy from things like local Healthwatches. So rightly, a strong focus on quality and safety, and we retain that every day in all of our institutions. A 10-year plan has been published for the NHS, just to remind colleagues that this is one of 3 priorities in the government's missions around health. The first is to focus on the wider determinants, and you'll see a really great example of that is the work on work and health. Later on in my report, there's a section about the Mayoral Combined Authority and the ICB working on a work and health programme chaired by the Mayor and myself to make sure that we are reducing economic inactivity in our communities. That's an example of that first priority of the government around the wider determinants, whether it's housing or employment or the economy, education. The second is to have a 10-year plan for the health and care system, and the third is to resolve issues in adult social care and create a sustainable future. That's being led through the Casey Commission, which is due to report next year in November. So this central plank of those three around the health plan, again, I've set out some thoughts in the paper. What that describes is, I think, a move to a set of arrangements which we would all embrace. So greater personalisation for people, whoever they are, whichever the community they're in, so that they receive and are part of and are partner in the services that will help them to have the best life and to realise their potential. That personal care being tailored in communities and in the neighbourhoods where they live through blended teams of people from the third sector, from social care, from the NHS, from general practice, from dentistry, from pharmacy, working in the interests of the person and delivering joined up care. That care to be facilitated by technology, artificial intelligence and standard technologies like apps, so that people know where to go, get good advice, and are well informed and are part of and partners in their care. Those neighbourhood services coming together in places where people need to access services on a bigger scale, and those places having providers who collaborate in new forms so that they can deliver that joined up care, with specialist services supporting them in the place and across West Yorkshire or the system within which they operate. So this kind of vision of this left shift, so thinking about the person and their assets, thinking about what support they need, providing that support through joined up services in neighbourhoods, those neighbourhoods coming together in a place with the Health and Wellbeing Board overseeing a group of neighbourhood plans to deliver joined up care and providers collaborating to deliver those services, very much in line with things that we've been wanting to see for a long time. There are then some structural changes in the 10-year plan, which will have an impact upon this partnership and the partners within it. So the idea that following legislation, NHS England will be absorbed into the Department of Health and Social Care. We have a smaller centre. The regions of that centre will focus on performance and quality. The ICBs will focus on strategic commissioning. The providers will focus on collaboration to deliver across systems or in places that joined up care that's needed, and that there'll be a single quality regulator which ensures that quality of services is good and effective. Those sets of changes will require some legislative change, so we'll enter a transitional period to get there. Significant reductions in NHS England and DHSC of up to 50%, a 45% reduction in the headcount and capacity within the Integrated Care Board, reductions in our provider organisations in terms of corporate capacity. This year and next year, we'll see substantial changes to the capacity that we have available to us, and I think has been fed back nationally a clustering of those changes in our city region. So we have the headquarters of DHSC and NHS England in Leeds. We have a substantial number of large public sector employers in our NHS organisations in West Yorkshire, and we have the ICB all affected. So we will see potentially an economic impact on that, and we'll work to make sure that that's minimised as far as we can. So those changes are taking place and are set out in my report, and come at a time when really we are focused on what we're here to deliver, which is improved outcomes and safe and effective services that everybody can access. And I think you can see the seriousness with which we take that from the agenda today, from the way in which we engage local people in feeding back in the development of the 10-year plan, and ensuring that we maintain a healthy focus on the things that really matter to people. Just a few leadership changes that I really did want to mention. So you can see from the paper that we can welcome Brent Kilmurray as the new Chief Executive of Mid Yorkshire Teaching Trusts. I don't know if Brent's on the call, he was earlier. Don't you want to say hello, Brent?
Yes, I'm here, Rob. Thanks for that. It's good to be here.
Great
Hello,
stuff.
everybody.
We're saying farewell to Dame Linda Pollard, and just again wanted to give my thanks to Linda for all her leadership in the system over the last few years. She won't be lost to us entirely, I'm sure, but her work in Leeds, in the Trust, in the Leeds Primary Care Trust, in Bradford Teaching Hospitals and elsewhere with the university and others, has been exemplary and made a huge difference. And we wish her success in the next phase of her career. And Tony Kildare has been appointed as the chair of Leeds Teaching Hospitals NHS Trust, so we will welcome Tony at the next meeting. And John Lawler will be joining Airedale NHS Foundation Trust on the 1st of August, I think the date is. John is known to some of us as the former Chief Executive of Leeds Primary Care Trust, as senior leader in Huddersfield Foundation Trust and elsewhere. And also I understand it's probably Brent, this will be the last meeting that Brodie Clark attends, I think, of the Partnership Board. And I know Brodie has been here today. I think he might still be here. And again, just wanted to give my thanks to Brodie, who's always been a really strong and supporter of the work that we do, and has been always involved in things like, recruitment processes, chairing panels, putting in the hard yards to make sure that we're successful. So I wanted to thank Brodie as well as he moves on as chair of Leeds Community Healthcare NHS Trust. In conclusion, I think, Chair, we've got a period of substantial and significant change in the structure of the organisations in our partnership. Some of those changes, are happening very quickly, including the ones in the Integrated Care Board, and there could be disruption. We have to remain focused on what the real job is. We are not the story. Our organisation as the Integrated Care Board, we're not the story. The story is, are people receiving good care? Can they access good care? Is it joined up? Is it fair for and open and accessible to everybody? Is it improving the outcomes? Can we deliver that with the money that's available? And we've got to retain our focus on moving forward on that agenda to improve outcomes for people. And there are changes in the 10-year plan. There are changes to the structures that will help with that if we get it right. If we're going to get it right as a partnership, we have to maintain, I think, our collective leadership and our collective resolve to work together. We've got this far as a group of leaders and a group of organisations because we do work together. And things like the Integrated Care Partnership existed before it was statutorily required to have one, because we recognise sometimes you have to work at this level with these partners to get things done. Sometimes you have to do this at place. Sometimes you have to do this at neighbourhood. So I would hope that during the transition and beyond, we can maintain an effective set of partners working in partnership in service of local people. And we'll have to do that very consciously. So as well as noting the things in the paper today, I would hope that we could all give our commitment to ensuring that as a partnership, we continue to work together and create the right kind of vehicles going forward to ensure we're making the most of every penny that comes into West Yorkshire for the economy, for the health and care system, and to improve outcomes for local people. Happy to take any questions.
Thank you very much, Rob. So there was a lot in both the written report and your update there. So let me bring Tracy in first.
Thanks so much, Rob, and thank you to you and your team for all that you're doing under enormous pressure. And it's great leadership. Thank you. Just one thing, and apologies that I came late. I just had a ministerial call. But did you speak to the neonatal review? And would this be a place to discuss it? How can we help the Secretary of State get to a point where we can support any changes or interventions that will make it more reassuring to have a baby in West Yorkshire?
Yeah, we did touch on it briefly, Tracy.
Oh, that's fine. That's fine. Sorry, I didn't hear it. As I say, I came late. Apologies.
That's okay. I think it's fair to say that we've got a whole spectrum of ratings. If you look at the Care Quality Commission, when it comes to the services, so we've got Bradford with an outstanding rating for neonatal services, and then we have other trusts who are good, and unfortunately some services that have been rated inadequate. Those organisations, whether they've come from a place of challenge to be outstanding or whether they're now in a place of challenge, need to work to adopt good practice from each other, to adopt any good practice from the national review. And I think our local maternity and neonatal system, which brings together all of the organisations, the maternity voices partnerships of local women and families, and the commissioners, is a good vehicle to do that. I think your suggestion that offering support back into the system is something we'd always want to do as well. And if we are engaged in any way as having an organisation that's one of the 10, then supporting that organisation to be in exactly the right place. Because what we want to reinforce is that the vast majority of women and families services are good and safe and effective, but unfortunately not always. And you have to work tirelessly to minimise the chances of things going wrong, and anything that improves the opportunities for us to reduce risk is welcome. I don't know if any of our provider colleagues want to add anything to that, but that would be my perspective on it.
Thank you.
Thanks, Rob. Not seeing anybody at the moment, so I'll bring Fatima in, but if somebody wants to come in and take that one forward, that'll be appreciated as well. Fatima?
Thank you, Chair. It was just to build on the Mayor's point, really, because there were references in the report to people experiencing discrimination. There was also some cultural references as well. And one of the things that we established as part of the evaluation led by the Professor Dame Donna Kinnair was an aspiration to really work collaboratively with the work taking place in maternity. And if there's something that we can do with the VCSE voices to supplement and support that, I think that would be a really great join up.
Thank you. There's no other comments at the moment. Perhaps I can just respond to and endorse Rob's point about the partnership working and the continuation of that. As said, we modelled this partnership before there was a statutory requirement for it. I think it's absolutely essential that we continue to work in that way. Health and local government don't exist in their own isolated silos. Our work is critical to each other, and actually our ability to deliver better outcomes for people and to remain sustainable depends upon us getting those connections right and genuinely supporting people to live better lives. So I am certain we will all want to see that sort of partnership continue. I think the other thing it's important to remember is that although the partnership board itself is the visible part of that, the reality is that the strength in West Yorkshire has been the embedding of partnership working at almost every level and across every different interest, both at place levels, but in terms of specific areas of work as well. That we have genuinely seen this as a whole system that brings together health, local government and the voluntary sector, and that we want to see that continue. And I think how we develop the neighbourhood health approach will probably be a really key part of that. If I were to go beyond brief and slightly beyond Rob's thing, I mean, just wanted to highlight, and I hope people will be aware, because I think it's an opportunity to mention it, people will be aware that tragically there was a case in Liverpool of a child losing their life because of measles. So I just want to take the opportunity to emphasise again, firstly, the importance of people being aware of the symptoms of measles, because it's not common. Secondly, recognising that it can be very serious. And thirdly, to plead, please to people, check your vaccination status and make sure you're fully vaccinated, because that is the best protection. And I'm sure many of us and many of our partners will be putting out messages on that in the next few days as well.
Yeah, thank you for mentioning that, Tim. And there is an active piece of work led by the medical director and partners to ensure that people can access vaccines, and we're promoting access to vaccines. Again, it's a really good example of close partnership working to maximise the uptake when things like this occur.
Thank you. Any more questions or comments on Rob's report? It feels like we're in one of those positions at the moment where there's almost so much going on. It's kind of a bit hard to know where to start sometimes, isn't it? And I do think, and yeah, add to what others have said, I think, to record our thanks to all of the staff who are involved for keeping focused on delivering for the people of West Yorkshire whilst coping with all this uncertainty, including, of course, uncertainty about their own employment and their own future prospects. We're with you, and we will support you in every way that we can through this period. Okay, well, if there's nothing else to pick up, if there's nothing else to add, I'll move us on then, if that's okay, to item 6, our ambition to reduce AMR infections. I'm not trying again. So can I welcome Sarah Chadwick and John Heritage? And I think it's Sarah who's going to introduce the item.
It is. Thank you very much. I'll just start showing green. Can everybody see that okay? Fantastic. Yeah. Okay.
Yeah.
Yes, do shout at me if anything disappears. I'm not sure whether John's here at the moment, but he'll be joining as soon as he can, if he can. So good afternoon, and thank you for inviting me to talk today. For those of you I've not met before, my name's Sarah Chadwick, and I'm AMR Programme Manager for West Yorkshire ICB. So I'm joined in the meeting today with Sarah Smith. So she's Associate Director of Improving Population Health Portfolio, within which AMR sits, and hopefully for the presentation with John Heritage, but we have a recording. And John's an academic, and more importantly today, a husband and carer with lived experience of antimicrobial resistance. So today we're just going to share West Yorkshire's AMR story again with you, a year later from our last introduction, and how it connects with the wider goals around equity, sustainability and safe, effective care. So you've received the full paper, so I'm going to take that as read. So just in this presentation, I just want to bring this to life a little, that this is actually about people. It's about families and the healthcare staff caring for patients behind that data. Because AMR isn't just that niche laboratory or pharmacy issue, it's about whether an infection is treatable, whether someone can recover at home with their family, whether they can continue with life-saving treatments that you can see there, such as chemotherapy or surgery, or very sadly, alternatively, develop a life-changing serious infection or sepsis and require the support of intensive care. Drug-resistant infections that already cause over 1 million deaths a year and could rise to 10 million by 2050. But I don't think that we should think of this as a distant problem. Last year, over 66,000 serious cases were recorded in the UK alone. And here in West Yorkshire, we're already seeing this: resistant UTIs, chest infections, surgical wounds. And as you know, these aren't rare conditions. These are everyday infections that now take longer to treat, come back more often, and are able to resist multiple antibiotics at times. And for patients and families, it's not just about trying another prescription. This means more pain, more serious side effects, more hospital visits, difficulties working or having less independence in older age. So I'd like you now to hear from John. I say it's a recording because he does have care responsibilities. He knows this reality very personally. He speaks not only as an academic specialist in OMR, but as a husband caring for his wife who lives with dementia and recurrent resistant infections. So please take some minutes to listen, and we do hope perhaps that John will be joining us later for the Q&A after the presentation if possible. So I'll just start this for you.
To introduce myself, I'm John Heritage. I have a clinical science background in microbiology, and for many years I taught microbiology at the University of Leeds, with a research interest in antibiotic resistance. For about 10 years, my wife has suffered from repeated urinary tract infections. This is just one part of a very complex health need that she's got, and for a long time I've had care responsibilities, and I'm now her sole carer, and it is a full-time job. Her bladder infection started off being quite easy to manage with trimethoprim treatments, but sadly she became documentedly allergic to trimethoprim. Over time, and with repeated urinary tract infections, her bug developed resistance to penicillins, although at a very low level, and so she could be treated with high doses for long periods. Ironically, this was a result of the resistance mechanism that I used to study when I was researching antibiotic resistance. To give you some idea of the scale of the problem, she would develop urinary tract infections about once every month or so, perhaps shorter, perhaps longer. This was very, very difficult to manage, and she became completely confused during antibiotic treatments. This made her care exceptionally challenging. Often she wouldn't understand what was going on or why. Alongside her confusion is the fact that urinary tract infections don't observe office hours, and so frequently I would have to call the 111 service and go through their extensive algorithm for a problem that I knew exactly what it was, and then we'd have to wait for somebody to call us back. And then I'd have to introduce myself as somebody who understood antibiotic resistance and her needs, which fortunately, in my experience, mostly the GPs that I spoke to were very happy to listen to and to prescribe. Another problem is that the antibiotic that's usually prescribed for Pauline is an antibiotic where the supply chain has been fragile, and quite often it's been very difficult to source enough antibiotic to give her a full treatment course. It can be quite difficult to explain the subtleties of her particular bug. It's resistant to the drug that we need to treat it with, but at a low level. It's because the resistance mechanism just binds up and reduces the effective active concentration of the drug that we can give her. It can be quite difficult to explain this because medical education doesn't really have time to fit in the nuances of antibiotic resistance and understanding it. Another big worry for me is that in terms of antibiotics available to treat infections in the community, we're in the last chance saloon. And if this treatment doesn't work, inevitably she'll end up having to be hospitalized with all the costs that are associated with that. And also, from her point of view, it means much, much more increased care responsibilities and challenges. So I'm trying desperately to avoid that. But there is another major problem with her treatment, and that dates back to the pandemic when she suffered from acute pancreatitis at a time when surgery couldn't take place. As a result, her pancreatitis was treated with a cocktail of antibiotics that led, probably inevitably, to a C. diff infection, Clostridioides difficile, a bug that's associated with use of antibiotics that leads to the most horrendous diarrhea and a potentially life-threatening condition. Her C. diff infection relapsed a couple of times and was really difficult to treat. And then a couple of months later from her pancreatitis, I was being treated with a proton pump inhibitor, and I too succumbed to a C. diff infection, which again was a relapsing disease. And every time she now has an antibiotic, I have a dread that she'll get C. diff again. So all of this sounds terribly negative. Is there any positive out of the antibiotic resistance, antimicrobial resistance story? Well, yes. We were very lucky to come across a specialist urology nurse who suggested that Pauline might benefit from hyaluronic acid treatment. Now, if you think of the bladder as a wall with the epithelial cells as bricks in that wall, hyaluronic acid is like the cement. And the treatment involves instilling hyaluronic acid into the bladder to essentially regrout the cell walls. Or to regrout the bladder wall, and that means that the bugs that normally cause urinary infections have got no little hiding places in the crypts between the cells. She's had a couple of courses of treatment with this, and the really good news is that this has decreased dramatically the number of infections. Before the hyaluronic acid treatment, she was probably having monthly urinary tract infections. Since this stopped, which was about 6 months ago, she's had a couple of bladder infections. And so combating antimicrobial resistance isn't just a question of reducing the number of antibiotic prescriptions that are given out. It's perhaps a question of thinking outside the box and looking for alternatives to antibiotics. And are there other ways that we can stop infections or reduce their risk? And I want to take that as the positive to take home from this story.
So thank you, John, for providing that recording for us. As you saw in the report, stories like John's and Pauline's are not rare. People with resistant infections tell us repeatedly that their healthcare providers don't know what to say or do when they've run out of antibiotics to try. AMR is also impacted by where people live, how they access care, and how joined up that care is. And we know that in our most deprived communities, prescribing is higher, and older adults are far more likely to be hospitalised with, for instance, a UTI, respiratory infection, and the costs associated with that are huge. For inclusion health groups, trust is lower, access is harder, and unsafe behaviours such as buying under the counter or sharing antibiotics follows. Our response then has to be human and consider social norms as well as clinical prescribing protocols, which is why we've been working with faith groups, schools, care homes, so that people wherever they are feel seen, supported and safe. Of course, what makes resistant bacteria really tricky is that they often live harmlessly in our bodies. But when something happens, like antibiotics, a catheter, lower immunity, they can tip into a serious infection. Every admitted patient brings their own gut microbiome into the hospital, and then over time, the environment absorbs the pressure of our prescribing practices in that organisation and the way that we deliver infection control. Now we're seeing resistant organisms not just in patients, but in sinks, drains and hospital plumbing. And that's why this can't be tackled with one team or one provider. People and bugs move between settings, and just one patient transfer can trigger outbreaks across multiple organisations. So the response has to be system-wide. Estates, facilities, infection control, public health, digital workforce really do all need to work together to design out these risks. So the good news is we're not starting from scratch. Despite inequalities and complexity, we've been leading in many areas. And whilst it's just one of our 10 big ambitions, reducing AMR also supports our other ambitions, those wider goals: health equity, safer care for vulnerable people, and environmental and economic stability as well. We've demonstrated in the paper some of the fantastic work happening across our system in detail, and there are some examples that you can see on your screen here. Over the last decade, we've also seen real innovation nationally, so rapid diagnostic tests, new antimicrobials, digital tools to guide prescribing. But despite this progress, we're already seeing resistance to some of the newest antibiotics for serious infection, and that news headline was just from April this year. And many promising diagnostic tools still aren't widely adopted across services. So whilst we're making really good progress in how we screen for resistance and manage infections, can still add to the problem. To change that, we need to close some of these gaps and continue to move our pockets of success across the system into a consistent system-wide approach that delivers safer, more sustainable care for everybody. As we're all aware, we're entering this period of significant structural change, and it looks like perhaps infection prevention and medicines optimisation within the ICB will be moving into provider organisations. So now more than ever, as resistant infections continue to be more complex, our ask is that you maintain that collective approach, wherever that may be, that's driven progress and brought us this far. Just recently, the Department of Health and Social Care told Parliament that while the UK can just about manage chronic AMR, responding to an acute emergency will be far more difficult. So I think preparing that coordination here is your safeguard, and it needs to be protected. So what do we need from you as a partnership? Well, we've still got a window to make a change, but that is closing. Resistant infections are rising, but we know what works. Things like improving surveillance and diagnostics, promoting the use of alternative treatments, such as things that John discussed earlier, and working with our citizens. We've really built some strong foundations. So as professionals, please keep AMR visible. Embed it in your local strategies and community commissioning conversations. Support those that are responsible for making really tough decisions on the use of antibiotics to have access to the best data, technology and diagnostics that we have available. Support the National Action Plan through your organisations and collaboration with others. And please encourage your teams, whatever your focus or your role, to become antibiotic guardians. This stewardship isn't about saying no to antibiotics, it's about making sure they still work for when we really need them. This is one threat I think we all share, and one that every action counts, really, to safeguard these crucial medicines for future generations. So thank you, and we're happy to answer any questions. Stop sharing.
Thank you so much, Sarah, and thank you, John, for sharing that experience, which was incredibly powerful and resonated in different ways, I'm sure, with other people's experiences as well. So open this up for any questions or comments. Okay, Tracy, yes.
Yeah, just to say that opening recording was really powerful, and the impact of the regular infections, and then coming to a point where not because they want the antibiotics, but because that's the only way for her to get well. And what an incredible person he is as well. So please do send our thanks for that quite moving testimony. Thanks.
Thank you, I will.
Thank you. Yeah, so somebody who's not a health professional, I found that really interesting and challenging, and a few comments. And I think certainly I'd probably come into this with sort of a headline thought that, oh, this is mainly about persuading people not to ask for antibiotics for things they don't need them for, but it was good to see the emphasis that actually it's much wider. And I think also there's some important things in there about system working, which I'll hold off for a moment and not misuse my position as chair, because we've now got 2 or 3 hands, but I might come back. So first of all, Fatima.
I'm all for you using your system leadership chair role because I think there's a great opportunity for us to make positive impact. Really comprehensive presentation, and lovely to see you again, Sarah and Sarah. A couple of suggestions. One is there's a great opportunity for us to really influence some of the work that the Mayor and other colleagues are leading on when it comes to place regeneration, housing development. So there was reference in the paper, wasn't there, to some of the socioeconomic factors, but also the way in which our homes, particularly those in communities of deprivation, are created. If there are some great suggestions or examples of good practice, I sit on that committee. I'm more than happy to pick up conversations outside of this meeting and feed them in. The other bit that I was really interested in was the role of poverty when it comes to healthcare access. And I think there's a really great opportunity for us in the context of strategic commissioning, but also the wider determinants of health, to really take this agenda in a slightly more innovative direction than focusing on just the clinical factors. So again, maybe one for us to take outside. The bit that I was really interested in, though, obviously as a carer myself, was the lived experience bit. And I know that, you're here, John, and it'd be great to hear from you at some point. We've done some work when I was leading the programme on developing the capability of unpaid carers with great sort of infection control practices. And I do wonder whether there is an opportunity for us to really build and consolidate on that, because people don't know what they don't know, and they've always got the best interest of their loved one. And when they're trying to navigate 111 and all these other areas, it would be really great to have some accessible information, even a video on what good looks like and what to do in certain scenarios. And I just sort of think there are some very quick and easy solutions that don't need to be clinically led to support, I think, one of our unseen workforces, quite frankly, to support their loved ones in a really meaningful way. But happy to discuss those suggestions outside, Sarah.
Thank you. Sarah, you okay if I take 2 or 3 comments and then bring you back at the point? So Nadra?
Yeah, that was an amazing presentation, Sarah, and also John. My point really, I've got a couple of points. One was I was really interested to hear about the environmental transmission of AMR and what we could do in terms of our new builds. And it's something that I haven't really thought of before, but I was thinking, yeah, maybe this is like a standing item in any of the buildings that we might be responsible for in the building in the future. That was one thing. And the other thing, I was thinking about how different communities respond to health services. I mean, we still have communities who will expect a magic pill for everything and are highly disappointed if they don't get an antibiotic. But really, I mean, I can't even begin to count the number of conversations I have at parties, funerals about not needing antibiotics. And I'm just wondering whether there are some gaps in terms of our campaigns and our awareness and our educational programs in schools and other places that we could actually begin to fill. Thanks.
Thank you. Louise?
Thank you. Thanks very much, Sarah, for that. Just say I'm Louise Bessick. I'm the Chief Exec of Bradford Care Association. So we represent independent social care providers, and I think there's a real opportunity to engage with the social care workforce on this. So your home care, your care homes, we support obviously some of the most vulnerable in the communities, and I think we could look at doing perhaps a big education piece around that, working with our local IPC teams just to raise that general awareness of this, because we do come into contact with it, but I don't think we necessarily have as much insight and awareness as we could, so that we could advocate for the people that we're supporting around this. And there may be some environmental changes that we could perhaps be aware of. It may not be easy to implement, but we can certainly have a look at those. But there's a real possibility there, and obviously that reaches into people's own homes as well, and can help that education piece more broadly. So yeah, I think that'd be really happy to engage if we can support with some of that, and obviously we work across with the other care associations across West Yorkshire.
Thanks, Louise. Really interested you made that point, because I've been thinking kind of what local government's role in this can be as well. And actually came up in a conversation in Calderdale that I thought, if we can make sure that frontline social care workers understand what the messages are, because I've been in situations where I've heard home care workers just having that kind of normal conversation of, oh, the doctor won't prescribe me with antibiotics, so they are in a very powerful place to help get the right messages over, aren't they, if we support them with the right information. Sarah Smith, sorry. Yeah.
Thank you. My name's Sarah Smith. I think Sarah introduced me briefly, but I'm a Deputy Director for Population Health and Consultant in Public Health at West Yorkshire Integrated Care Board. So I want to say a couple of things. I think, Sarah, I really like the way, and it reflects the work that's been done in this space and the system work over the last few years that you've led, that you really kind of show the human aspect of this and the behavioural aspect of something that's really quite technical and healthcare technical, but show the kind of the role of the whole system in this space. I think so important, because we've all got a role to play, as you tell me frequently in this agenda, and there's some real practical things we can do as our organisations and as individuals and as a system. And I think coming onto that system piece, just wanted to really kind of flag up in the paper was referenced, but the collective work we've done on health protection as a system, and our system response now to health protection that we've done working with local authority colleagues, namely Directors of Public Health and UK Health Security Agency, that's been sort of nationally recognised in this space. And it links to the work you were talking about earlier, Chair, in relation to sort of measles vaccination work as well. And again, just a plea that we keep that on the agenda and don't lose that through the kind of current system changes, because it's something we're sort of seen as excelling on as a health and care partnership that'll help us drive forward the infection prevention agenda, but wider health protection issues as well. And it's something we're working on together with Directors of Public Health through these changes. But yeah, excellent work, Sarah, and lots of learning for us from this.
Thank you. Rob?
Yeah, thanks for the presentation and the work that's gone into it, and the work that continues to go into this critical area. I noted the real successes on, growth in prescribing of alternatives, and also in, reducing the length of prescribing of the courses of antibiotics that we've been implementing through West Yorkshire, which is good to see. I wondered if, sort of two questions really, sort of the general issue of pressure in the system and high occupancy rates and people in temporary escalation spaces, I presume it is a cause for concern on this agenda. And is there anything we need to do over and above what we're doing because of that? So that's the first question. And then secondly, is there something about tailoring the interventions to the communities and to the staff profile that we have? So really support Louise's points around care staff, conscious that significant number of the public and there'll be some issues for our staff around language, and also for the public there'll be something about ability for people to understand the arrangements, which can be quite technical if we're not careful, even to know what to ask for. I mean, John's experience is really powerful, isn't it, in terms of what people should be considering. So are we doing enough in our diverse communities and with our staff to communicate how this should work, and not have, or are we relying on a sort of single type of communication and intervention which is tailored towards the majority? So it's those two, please, if you've got a view on those.
Okay, it's a good point to bring you back, Sarah.
Thank you. I think probably that conversation will speak to a few of those other questions as well. So I don't think we can ever do enough. I think we've done incredible work with communities. So this is kind of with co-production with small groups of underserved communities, hard to reach communities that were, or not hard to reach, underserved communities that we have gone out to, worked with, and really focused the language of the resources that we've been developed. We recognise that a lot of the national resources that just weren't landing well, weren't speaking to either carers, unpaid carers, members of communities, or other healthcare professionals such as domiciliary care providers or social care. They weren't being recognised in some of the imagery that was being used. So we've created kind of a suite of educational resources, some videos, so that perhaps some of those language barriers it has spoken word on. I think what we'd appreciate its capacity to get that out there. To really sit almost knee to knee with people working in care homes and social care providers, rather than send out a video, or to its real kind of capacity to be able to do that work. And there's capacity in the system within your organisation. It's really great to have those offers for us to be able to work with people going forward on that. But we have got these resources that we've developed in West Yorkshire, specific for West Yorkshire communities, that have been celebrated. So and some have won national awards. So we feel we're ready to take that out there, and really welcome your support with that. I think that probably covered most of the questions, probably apart from the environmental aspect. So that we considered, and we do have leads within our system within West Yorkshire that have been asked to deliver and lead on some of this work nationally again. And there's been, this is quite a new area to us in infection prevention, but one that's really significant when we're looking at some of these really resistant organisms. If we want to really make a difference, we're going to have to start thinking of that. So I would hope that with all the new builds and new hospitals, there is that infection prevention link and conversation happening. But this is a growing area, and I think just to have your support to acknowledge it is wonderful. So thank you very much.
Thanks. Rob, do you want to come back?
Yeah, I think it is such good work, and there's so many useful co-produced resources. I think your comment, Sarah, about being knee to knee with people to talk through what this means really points to an improvement approach, and maybe a social movement approach. And whether there's any commitment you want to secure from all organisations in the system, given this is one of our 10 big ambitions, to engage in a piece of work which would look at how this becomes an improvement priority for every organisation, and something which we could get behind. I know that hesitate to say these kinds of things in straitened times, but as your material shows, if we don't get this right, then we're on a journey to somewhere incredibly difficult in the future. So if people would be interested in that, or willing to commit in principle to that, then I think as a partnership we could get the partners to work to try and at least align the resources and maybe go a bit further.
Thank you. I think, from the tone of the debate, Rob, I think there certainly would be strong support for that. And as you said, it's such a critical issue. I think, I slightly hesitate saying this because I'm an amateur talking to a room full of professionals, but again, slightly from personal experience as well, though. I mean, the system connection that stood out for me, and it's been picked up in the few comments with UTIs and managing UTIs, is huge. And I echo John's experience of having been a carer about just how disruptive they are. And I think also when it's, from my experience, when it's secondary to the main condition, you find that you're talking about it to so many different professionals that getting and I know, Sarah, I think you came to Calderdale and I talked to you about this, actually getting a consistent message about what the right treatment approaches are and what the options are is really challenging. And it feels to me that's probably something that feeds in a little bit to the development around neighbourhood health and multiple team workings. But of course, it's wider than that because it's also about consultant advice and so on. So that's really a spin out from it. But it just feels to me that like that's probably an area of work that is generating huge demands and pressures in the system and causing a lot of misery, quite frankly, for the people being cared for and helped as well. And I think the other thing is interesting. You picked it up, Rob, slightly. John's example about ringing 111, and I'm sure is wider. How do we make the system manage better when we've got basically transactional bits of the service who try to follow a script, who actually are dealing with people who largely, who know more than they do, whether that's because they've got professional background or because they're a carer by experience. So again, it does feel to me that a lot of that perhaps feeds back into what we mean by neighbourhood health and how we get those joined up teams. So Rob, yeah.
Sorry again, just in response to that, and I think, and please do say if we've done this already. Mel had asked the question in the chat about whether you'd got together with the medical directors from the acute organisations, and there is probably an opportunity for medical director from YAS or chief paramedic from YAS as well to get together with the medical directors from the acute hospitals and the team to come up with a set of language options, consistent SOPs, whatever it's going to be, that could be deployed in all of those places. That's a much smaller group than all of the clinicians or doctors across primary care and neighbourhood services. That could be the second phase, I guess. But we do have the meds ops work. So I think that it might be a useful intervention to take up that approach. You haven't already, Sarah, of talking to the medical directors and trying to come up with something, but including the medical director from YAS. So you get the 111, you get the kind of acute end of things, and we start to look at what we do there after that in the neighbourhood health services.
Thank you, Sarah.
Yeah, absolutely. That sounds a great opportunity. So thank you very much. Yeah, take that forward.
Okay. Thank you. And John, I don't know if you want to add anything, but thank you again for sharing that experience with us, because yes, over to you.
I'd just like to thank you for the comments you made, and I'm delighted that you found it a powerful story. It is my lived experience, and probably the lived experience of carers. I think, we love the people that we care for, and we do what we can for them. So I'm very grateful. And if any of you would have use for my presentation, I'll clip the beginning off for you. If you want to get in touch via Sarah, I'll send you a copy of the clipped presentation for whatever you want to use it for. I was born teaching, I think. If I can change minds and broaden minds, that would be the most fantastic thing that I can do for you.
Thank you very much. And I think there was already someone in the chat saying, could they use it? So I'm sure you'll get some takers, and that really is appreciated. So thank you very much. I think we've pulled together the actions we want to take on that item. And thank you very much for your time, Sarah, and John, and thank you for the presentation again. Okay, so not far off, I'll take us on then to item 7, which is our ambition to tackle climate change. And I think should have Lucy Kempster and Dr. Stephanie Chu to introduce this item.
Hi everyone, my name's Lucy Kempster. I'm a public health registrar working at West Yorkshire ICB in the Improving Population Health team. And I believe Dr. Stephanie Chu should be joining us. She might be here somewhere. I'm just going to share my slides quickly.
Hi, Lucy, it's Lauren. Just to say, Stephanie is here. I've seen her. She's popped up and she's waving. So just to reassure you about that.
Thank you. And can you see my slides okay?
Yes, absolutely.
Thank you. So I've been in the working at the ICB since December, and I've been supporting the climate change work since then. And I've also got Sarah Smith here joining me, who's already just been here, but Deputy Director of Population Health team. So thank you for letting us provide this update. I'll trust that you've read the report that I supplied already, and I'm just giving you a few key bits from the report so we can get on to hearing from Dr. Stephanie Chu and her work. So I wasn't going to go over the impacts of climate change, as I'm sure you're well aware, especially with the recent heat waves and drought. It is here already and affecting us. But I wanted to just go over a few of the key achievements that have happened since the last update. And that, so the ICB have continued to support climate change fellowships, and that's who you'll be hearing from next. There's been a lot of work across the system of promoting circular economy principles. So that's about prolonging the life of resources. So reusing, repairing, recycling things. And one of the projects has been working on recycling diabetes insulin pens, but there's been a lot of other projects in that space. A key kind of progression is upgrading a lot of the estates across the system, such as changing the fluorescent lights to LED lights and installing solar panels. And just to give you an example of the difference that can make, so Mid Yorks Trust received a grant to replace their fluorescent lights with LED lights, and they're replacing 16,000 lights over the next 2 years. But that's going to save £500,000 in electricity bills, and also 500 tonnes of CO2, which is equivalent to 2% of their overall carbon footprint. So some of these changes can make a huge difference, both for the environment, but also financially. Sarah from the previous presentation has already mentioned this, but altering medication practices across the system, such as reducing antibiotic kind of lengths and changing from IV to oral tablets. And then there's also been a lot of work to continue staff training, which is so important, as we know, as we need everyone involved in this. It's not just a climate change team problem, it's everyone's. As you've seen from the report, I wanted to touch a bit on the ICB and how it may change things going forward with the new role of strategic commissioners. And I've just linked a few things as strategic commissioners and how this could impact positively for the climate change work. And a big part of that is continuing the partnership working and the sharing best practice across the system. I think there's a lot that we can do on sustainable commissioning principles, such as impacting service specification criteria and including environmental outcomes in contracts. Sustainable models of care is a huge area that really needs to be impacted to improve our carbon footprint. So having leaner pathways and prioritising prevention and early intervention. And then I've already talked about this a bit, but really emphasising the co-benefits of sustainability. So nearly all climate action work will improve population health. So better air quality, more physical activity, better diets. It's better for the planet, it's better for health. And with that, financial gains as well. So just to go over the action and support would like to emphasise going forward. So I've already said this, but climate change mitigation and adaptation is everyone's responsibility. We really need the continued efforts to embed it system-wide. So that would be integrating it into governance structures, strategic planning and operational delivery. We really do need to reduce our carbon footprint and prepare for it going forward. So not only mitigating the effects of climate change, but also adapting services to the kind of inevitable, to the drought, heat, floods, all of that. And then, as I've already mentioned, really focus on the co-benefits. I think that is something that both colleagues and the community can engage with, things that are better for the planet, better for the health, and also the financial gains and reducing health inequalities as well. So these are the key recommendations that were in our report. And yeah, just noticing the progress that's been made, but there's still a lot to do, and thinking about how we, as the ICB, will act as strategic commissioners going forward. Thank you for letting me give that brief update. I'm now going to hand over to Steph, who you'll be able to introduce yourself properly, but she was one of our climate change fellows last year. Thank you. I'll stop sharing.
Thank you, Lucy, for the introduction and for the invite. As mentioned, I'm Stephanie. I'm one of the kidney registrars in the region, and I did my Improving Population Health Fellowship in Climate Change last year. Just going to pull up my slides. Is that sharing okay?
We can see those.
Okay.
Yeah, perfect. Thank you. So my project is titled Trunk HD, which stands for Trying to Reduce Unnecessary Carbon in Hemodialysis. So this was a regional sustainable quality improvement project in our Yorkshire and Humber Kidney Network and involved 6 different kidney units in our region. And the reason why we chose this project to focus on last year is because hemodialysis is a high cost and also high carbon emission treatment. A study by Newcastle estimated that a hemodialysis patient per year will emit 3.7 tons of carbon dioxide equivalent emissions, in addition to the average carbon footprint of a person in the UK. So this is equivalent to about 50% extra. So if we extrapolate this to the 30,000 patients on dialysis across the UK, this would roughly equate to about 100,000 tons of carbon dioxide equivalent emissions. Now, although this is not actually mentioned in the NHS 10-year healthcare plan, but there is a predicted 400% rise in dialysis users by 2033, which means that our overall carbon emissions could jump to 480 tons of carbon dioxide emissions. And why is that? So dialysis emits a lot of waste. You can see here, this is the waste collected first thing in the morning in our dialysis unit. We use a lot of consumables and pharmaceuticals, and this waste is collected 5 times a day in units operating 6 times a week. And we also excrete a lot of plastic waste and use a lot of water. A dialysis session itself can consume almost 400 liters of water in a standard 4-hour dialysis session. Not only that, we have to get our patients to and fro dialysis between 2 to 4 times a week. So there's a significant amount of carbon emissions from transport-related emissions as well. And what is often missed is our patients are particularly vulnerable to the effects of climate change and to extreme weather events. In the US itself, the Hurricane Helen damaged one of the manufacturing plants, which disrupted delivery of peritoneal dialysis fluids and IV fluids to hospitals. In the UK, as Lucy has mentioned, we are experiencing extreme drought, which to the general population, the minor side effect of it is the hose pipe ban, but to a lot of our dialysis users, this can cause a certain amount of anxiety, as mentioned, that dialysis requires a significant amount of water per session. So our project is divided into 3 strands. Strand 1 is doing tried and tested interventions that has worked for other units in the past and implementing them across our units. So I won't be able to go through each intervention in detail, but these are the 4 interventions. So reducing dialysate flow rate to reduce water and dialysate acid consumption, priming the machine itself with the patient. So for example, instead of turning the machine on before the patient arrives, which could be delayed because of transport, thus wasting a lot of energy and water, we only turn the machine on when the patient has arrived. Optimizing machine heat disinfection cycles to reduce energy, water, and disinfection use, and encouraging patients to bring their own blankets to the unit instead of using unit laundered blankets, which when you think about it, each blanket will have to be washed after just 3 to 4 hours of use when they could be using their own personal and probably more comfortable blanket during their sessions. Strand 2 is working with units to develop their own sustainable quality improvement projects to target issues specific to their unit itself. For example, in Bradford, we look at streamlining the dialysis line and fistula packs to remove unused, unnecessary items which contribute to plastic waste, but were actually not being used at all in their line packets, switching from single-use to reusable visors, and reducing pharmaceutical waste. In Leeds, we look at switching to a more concentrated form of acid, which reduces plastic and also transport emissions, because that means there was a less heavier bulk of deliveries. So it reduced transport emissions significantly. We also did recycling of the acid canisters that were previously going into the clinical waste bin, and a simple act of switching it to the recycling bin saved quite a significant amount of carbon emissions. And in one unit, they also look at reducing food waste. In Doncaster, they were streamlining their work process to switch to by upgrading their IT systems to reduce paper waste. And in Hull and York, we look at incremental dialysis. So instead of starting at a standard 3 times a week, 4 hours each time for dialysis in our patients, which was used to be our standard treatment of care, we now look at more personalized approach of prescribing dialysis. So it's suited for each individual's patient's needs. Strand 3 is using the online in-center hemodialysis carbon calculator to estimate our carbon emissions in the unit. So I'll just bring up the Bradford's example. So you can see here, patient travel, consumables, and pharmaceuticals was a major part of the unit's carbon emissions, which led them actually to form ideas for their Strand 2 projects. In Leeds, this led us to examine whether our patients were dialyzing at their closest unit. So we have 8 dialysis units. To summarize, in the pie chart, those in green are patients that are dialyzing in their closest unit, and all the other colors are patients that are dialyzing not in their closest unit, but could be dialyzing in another unit closer to home if the unit had capacity to allow it. Unfortunately, this isn't the case, but it has given us some insight into future dialysis expansion planning. So it's quite a short session that was given, but this is just a rough, quick overview of the interventions that we have completed and the annual greenhouse gas emissions that we have saved. So we predict that we will have saved over 45 tons of carbon dioxide emissions in a year, and also 70,000 pounds. And if we expand these interventions across all of our dialysis units in our region, we could save almost 120 tons of carbon dioxide emissions and 200,000 pounds per year. So one of the main barriers in the project was resources. So a lot of the units didn't know why sustainability is focused right now, or what sustainable interventions they could do. So it involved a lot of compiling resources on the interventions that they could engage in their unit. And then another major barrier was also staff and patient understanding or attitude towards the project. So some think that some of the interventions were a cost-cutting exercise, or that sustainability was not part of their responsibility. So it took quite a lot of changing in mindset in order for this project to be successful. And as Lucy has mentioned, the value of sustainability is actually it not only improves or maintains population and patient health, but it also reduces the environmental, social, and financial impact of the services that we provide in the NHS. Thank you. And we've also developed a resource page for other dialysis units in the country to use based on the projects that we have completed. Sorry, it's quite a quick run through because of the time. I'm happy to take any questions if there's any.
Okay, thank you very much, both of you. So let me open that up for questions, see if there are any hands. In that case, all right, yeah, no people got there. Okay, so Louise, yeah.
Hi, yeah, really interesting presentations, and I think there's a real opportunity again if we could work with social care providers on this. Currently, adult social care providers aren't being assessed against the environmental quality statement from CQC, but that will change, and we are constantly getting providers who are already trying to work towards that, but are a little bit unsure where to begin, how they can work through this, as many of them are smaller organisations. Some have their own estates, others are sort of community based, etc. So there are some obvious things that we can do, but what we'd really love to do is obviously to be learning and working on the expertise and the knowledge and insights that you've all gathered from the larger organisations, etc. And sharing that best practice. And yeah, I'm sure it wouldn't apply just to adult social care, it would apply to all sort of smaller organisations and setups, so particularly those with maybe slightly older estates and not the ability to make changes or the funding to make some of the changes, but I'm sure there are small wins. So it'd be really good to see how we can develop this to roll out more broadly to smaller organisations as well, and how we can then, look towards developing our own sustainability plans, and just also looking at sort of the contingency arrangements that we might need to look to in the future. With the heat wave that we've recently had, we're going to see more of that. What adaptations do we need to start to look at, and making sure that they're environmentally sustainable as well, not running fans and things like that, I'm sure is probably not the best idea. But yeah, we're really keen to get involved, and so we can support providers with this.
Thanks, Louise. I think there's probably a couple of things there for local authorities to pick up as well. I mean, there's some support for sustainability for small businesses, from the business side rather than directly the care side. We need to make sure those are linked up. But I absolutely recognise what you're saying. It's very hard for small organisations to have the expertise to do all of these things. Anne, can I come to you next?
Afternoon, everyone. I'm Anne Carroll. I chair the Wakefield District Health and Care Partnership Committee. Really interesting presentation. Just a couple of comments, really. And actually, I think you mentioned this right at the end, but I'm just wondering if the title of some of this work should be not just the impact of climate, but environmental and sustainability, because sometimes, the general population think about climate change as nothing to do with health, but actually what we are talking about here is really important, because the impact on the environment of the waste products within the health service, and the work that's done within the health service, as you say, produces a massive amount of packaging, particularly. And my second comment, which was really something to think about, was the recycling of pharmacy packaging and the blister packs. There is work done already on that, but actually it's really quite small. And if you try recycling the blister packs, Boots have a thing, but you have to download an app, and so it's not absolutely easy to do that. So I think there's quite a lot of work we could do nationally to nudge people into recycling those blister packs, like we've done with plastic bottles and plastic bags. I think there's a significant amount of work that could be done. Most of those blister packs end up just in the ordinary housekeeping bin. Those are my two comments for us to maybe think about as a West Yorkshire partnership.
Thank you, Anya. Excuse me for laughing, because I was about to bring up blister packs as well. I kind of kept all the blister packs we generated when my wife was ill in a month, and it kind of was a big carrier bag full. I mean, I think there, and to broaden it, I think perhaps one of the conversations is a question about suppliers and the way they provide things, because actually blister packs are really difficult to recycle, which is why nobody does it. So they're actually difficult to reprocess. And probably the real solution is finding a different way of producing them. Rob.
Yeah, so 3 points really. So I think there's an opportunity here, isn't there, because of this work, to think about what we commission as a strategic commissioner, and what we expect to see in that commissioning set of processes, or any quality premium that we might want to put into the work that we do. Because it seems to me that the work that Stephanie shared with us is a really positive piece of work, that looks at how you create a more productive way of doing things, a more efficient way of doing things, and one that's better for the environment, better for the patients. That triple bottom line was really strong, I thought. And if we looked at that's just in dialysis, and then if we looked at other clinical areas, I'm sure that there's other work. So we could position this as a productivity piece as well as something that supports the environment, and think about what we do therefore in terms of our strategic commissioning, seems to me, as a strategic commissioner. I think the second thing then to recognise is that responsibility for the green agenda, according to the 10-year plan and changes announced by NHS England, will transfer to providers and away from the Integrated Care Board. This seems to me to be, some examples of really good work that providers could be considering, particularly around this way of making change happen, this kind of clinically led work. And I think, Stephanie, you said that this was part of the fellowship programme that we've had in place. So it's great to see the fellowship resulting in real change, and these small amounts of investment in people like Dr. Chu and Dr. Smith, are really making a difference out there, and we've got to continue to think about those sorts of things. So let's look at that, and then the third thing is I would hope that the modern service frameworks, which are identified in the 10-year plan for some significant conditions, will take this kind of approach. And this is a set of standards which diabetic care, mental health care, other services will be held to nationally. And it seems to me we should be lobbying for that to be a consideration as part of MSFs. And if you put those things together, you can see how in the new system we want the same outcome, but we're going to have to think about how we get there with us strategic commissioning, the providers working on productivity and improvement together, and maybe having a set of national standards and incentives that reinforce that.
Thank you, Rob. Sarah.
I think building on some of Rob's points really around that system value piece here, I think Lucy really well sort of summarised and demonstrated, then Stephanie brought the detail in on how the interplay here between value for money, value for patients in terms of experience and positive impact on climate change. And big thank you to Lucy, who's done this as a public health registrar with us, and a shout out to Richard James, who's a consultant with us now, but had done some previous work, Louise, on, I popped it in the chat, on sustainability in care homes, and a toolkit there that I think could be really applicable in the social care sector as well, so we can do some learning from that. And I think it'd be remiss of me to not say, with Frank Swinton, who used to be a climate change lead, who would always say the biggest thing we can do from a population health point of view to reduce the impact we have on the climate is to prevent ill health in the first place and promote healthy lifestyle. So I think that wider primary and secondary prevention agenda and keeping people healthy is one of the biggest things we can do as a health and care system to have a positive impact on climate change. So I think there's such a big interplay between all of these outcomes here that we can really have an impact on in the future in our sort of strategic commissioning role as well.
Thank you. Fatima, any final comment?
I am so inspired, Dr. Chu. That was a phenomenal presentation. Thank you for sharing that. Really briefly, I just want to challenge the Partnership Board with its thinking about maximising the use of all its partners. So if there is an opportunity for us to lift and shift elements of good practice and put it in the Fair Work Charter compendium of resources that we've got, why don't we do that? That's a quick win. If you've got the document, I can make it happen. And then the other bit is going to Sarah's point about active travel and, the prevention of ill health. There is so much work happening in the combined authority local government space on active travel. I think there's some opportunities regarding Join Up that we're maybe not maximising. And is there an opportunity for the board to harness that in a way that will truly deliver some of the change? I take the point about it being an organisational responsibility, but I never hesitate to think big to get the maximum impact.
Thanks, Fatima. The challenge of sharing some of these bits of best practice and seeing where they can transfer into other processes as well is huge. Thank you. That's been really, really enlightening and challenging. So thank you, Lucy and Stephanie, for your presentations. That was great.
Thank you.
Thank you.
We'll take a short 10-minute break at this point and restart at just after past. If that's okay with everybody. Thank you. So good afternoon, everyone, and welcome back to the West Yorkshire Health and Care Partnership meeting. So our next item is on health and housing, and I'd like to invite Rachel Loftus and Jen Connolly to present this, please.
Thanks. I'm going to start sharing my slides before I start speaking, just to check I have done everything correctly. Can everybody see that?
We can see your slides, Rachel.
Yeah. See your notes I see what you mean. Yes, you can't see. Hang on. See, I can tell. I should have done that now. Still including sound. Is that it there now?
Perfect.
Spot on.
Brilliant. So for lots of reasons, we have chosen to present an item on health and housing at two separate West Yorkshire bodies within a week of each other. Last week, we had the pleasure of going to the Combined Authority Place Housing and Regen Committee to talk to the same paper, and of course we're today coming to the Integrated Care Partnership to do that, because it goes without saying in lots of places, but health and housing cannot be separated. They are a fundamental driver of health, and health and housing appear in most aspects of people's lives. We're doing some brilliant work across West Yorkshire, and as evidenced in the appendices, but the housing crisis combined with poverty, combined with many other factors, is meaning that too many people in West Yorkshire are being made ill by their housing. Their health is being exacerbated and worsened by their housing situation, and the national framework around how housing and health work together isn't as integrated as we would like it to be. So as ever in our West Yorkshire way, we are dealing with the reality of what we've got and doing our best to join those things together. But we're going to kick off first by hearing some voices of some people in West Yorkshire who have spoken to Health Watch about their experiences of living with poor and inadequate housing and in ill health. So Harriet and George from Health Watch Leeds, on behalf of Health Watch West Yorkshire, have collated these voices, and we thank the people also who've got their voices in there but who've chosen not to be named. So I'll press play on that and hopefully that will work.
Health and housing. We had a group discussion with 3 people about how their recent housing issues have impacted on their health. We'd like to thank them all for sharing their experiences. We spoke to someone who told us about how their daughter's health has been made worse by their housing situation. Her child has many different food allergies and sensitivities, which have been affected by the damp in her house. She carries an EpiPen and her allergies are very serious.
My second child, she is very sensitive. She have EpiPen. The house is too cold for her. All the money I get, we put it for the heater, but it's not enough. When I went to the council to speak about her as well, nobody listened. If you want, leave the house, go to the private house. But how can we manage? Just my husband only, he work. But me, I lose because of my pregnancy, my job. Since that, I don't have any confidence to work. My child, because of the smell, she faint. Nobody see it like a big issue. Sometimes, if it is English, your second language, it's very difficult to explain all the pain. And then all I struggle. We try, nobody listen to us. 5 years, I was struggling. All my life is home and the hospital, home and the hospital. When we go to our house, we never been safe in our house. We live with rats. They eat all my sofa. They eat everything. But at the end, I found someone like John. When he called the doctor, the nurse, they came to my house. They came, they checked. When the doctor, they prove it, how they affect her. But after I found someone act on me, I get house. The way I live now is very beautiful, but the way I live in here is the drug user is everywhere. And then when we call to the police, because of our English as well, the police also, they never listen. Even sometimes the dog is better than the human. When our kids, they born here as well, they deserve to be equal with the others, but they are not like that. That's why I want to see a lot of change. That's why I'm speaking up for the others as well. They have to listen to the people problem instead of ignoring. Because when they ignore us, we lose our child life.
We also spoke to Patrick, who is an older age adult living in retirement housing. He told us about his experiences of feeling unsafe in his building and struggling to get action to be taken on issues with the building, such as leaks and rats.
For an elderly man like me, living in an old age pensioner building, they have taken steps gradually to phase out what we think was actually good. For example, there was one permanent person resident to look at the affairs of the people in the building and to see that people coming into the building are those that are supposed to be in the building. But what is happening now is that even outsiders are able to come in. You end up again being harassed by these people. I've undergone that myself. If you are a migrant who has run away from a country where you could have been killed, your mind is not as stable as the man beside you who has never seen or never heard of such a thing. So you need to have a chat with people like that, to see what problems they have so that they can also improve their health when they are here. Because some of them have sleepless nights. We need to develop an attitude of assisting people who are here. And the other things that have come up now, like the roof in the building is leaking. If it continues, the floor might collapse and it might actually kill people. And you will see that around the place, there are rats roaming around, and the building has got mice. The tenants have now got to start, going out, running at rats and trying to kill mice in their buildings. These are things that are preventable. Authorities should listen to people's complaints. They should not come to conclusions because of, color or language. They should actually look at the facts and see how they can help this particular person.
Finally, we spoke to someone who told us about how their child's health has been made worse by their housing situation. Even though she's struggling to get support from the doctor for her child's suspected allergies, the doctor identified that the house wasn't suitable for their health, but they've still been struggling to move.
My problem is my house and as well the first one, my son. I have eczema and everything allergic.
But the doctor, they told her already that house is not suitable for him. You have to out as soon as possible. But still, she's not living in the suitable house. But the child, they have the house problem because of he have itchy skin. She's suffering, but she living with a damp house. It's not suitable house. She have a lot of that. They eat everything, her food as well. Yeah, she lived 10 years in that house, but 7 years she been, but still nobody help her.
So you can see, even with just those few people speaking, the number of kind of the span of health conditions, the span of impact on your life, that when your home is not safe or your home causes a risk to your health, it really can impact across your whole life and across the whole life of your family. We do have some significant challenges in our housing here in West Yorkshire. Some of it is the relatively high cost of poor housing. So as we've seen in all parts of the country, house prices have increased, rental prices have increased, but particularly the proportion of your income that is required to maintain a house or to maintain a home in West Yorkshire is significantly more proportionate to the average income in West Yorkshire. So this is one of the reasons why it particularly drives more people to being impacted by poor housing. The other one is the lack of available affordable housing. There's lots and lots of reasons for that, and we see that there's been significant efforts in the last few years to try and turn that around in terms of to increase the number of affordable houses. But even though West Yorkshire has been proactive in building more than many other local authorities, all of the authorities in West Yorkshire have tried to really invest in affordable housing. It's not been something that has been able to meet pace with the demands, and that's by the increasing population, but also the increasing number of people who require affordable housing and cannot keep pace with private sector housing or the cost of buying your own home. So those factors combine that mean that the availability of affordable housing is quite scarce in West Yorkshire, and bearing in mind we have an above average number of people who are under the poverty line. The other part of it is around how to maintain a home, because it's not just the quality of your home or the cost of your home, it's your ability to live in it well. And we can see the cost of fuel, and that includes both to keep a home at a warm temperature in the winter months, but actually at a reasonably cool temperature. And as we've seen during the heat wave, this really has a massive impact on people who cannot afford mechanical ventilation or other ways of keeping their home warm or cool. And those combined factors in West Yorkshire really are quite stark. We also have a significant issue around homelessness, rough sleeping and hidden homelessness. We also have recently, with the West Yorkshire Housing Partnership, had a summit on the crisis impacting temporary accommodation. So the combination of factors that I've just previously mentioned means that we've got the largest number of people living in temporary accommodation in West Yorkshire as we have ever had since records began. And we've got people living in temporary accommodation and unsuitable temporary accommodation for a lot longer than we've ever had before. This is because the lack of available alternatives to housing is significant, but also the number of people who cannot maintain a tenancy in the private sector is there. And then similarly, with requests for medical rehousing, these have roughly increased by 10 times in the last 5 years. I don't think that's because the raw number of people requiring medical rehousing has increased by that much, although there are larger numbers of people whose health conditions require rehousing. But it's that availability of suitable housing in the private sector and the affordability of that combined with people whose conditions mean that they generally have a decreased availability of income to be able to do that. So we have a significant challenge across our housing sector in West Yorkshire, and equally we've got that affects people at all different times of their life. You can see there it happens prenatal. We see significant risks that are increased for mothers and babies and families at a prenatal time, if you are in a home that's unstable or unsuitable for you. And you can see some of the risks that increase there. Similarly, throughout childhood, the number of years that you spend living in a poor quality home can have a significant impact on your life chances. It increases the prevalence of mental ill health, it increases the rate of infection, and then massively increases the rate of respiratory problems. And just linking back to some of the earlier items, antimicrobial resistance and the overprescription of antibiotics for children with respiratory infections and other infections because of their housing is increasing. Again, across the age spectrum of disability, we've got about half the wheelchair accessible homes in West Yorkshire that we require for the number of people who require a wheelchair. So we've got an awful lot of wheelchair users and people with significant mobility issues living in a home that is not suitable or purpose-built for them. We also see across the disability spectrum higher rates of infection complications, higher rates of falls falls and accidents, and that's combined with that disability premium that we talk about and the higher cost of living expenses to live, which means that the availability of a suitable home plus increased costs makes living in an unsuitable home disproportionately high for people with disabilities. In adulthood, again, for every year you are spent without a decent home, the chances of gaining and retaining employment decreases. It increases the stress and strain on your mental health. It has a significant correlation with relationship breakdown. In fact, it's one of the number one causes of people presenting to local authorities as homeless is because of relationship breakdown. That's romantic relationship breakdown as well as familial breakdown, and it significantly delays or impacts people's ability to have continuity of care if their home or housing situation is either constantly changing or that you don't have a significant base to recover from. And similarly, in older age, we're seeing massively increased risks of falls depending on the quality of your home, the severity and rates of respiratory illness, again linking back to that conversation on AMR. There is significantly faster cognitive and physical decline noted in homes that people cannot live in, as well as that significant impact around social isolation. We know that connection is something that is connected to wellness and staying well, and living with ill health and in a poor home massively increases your social isolation. So, we see this impact all across the health and care system. We see it in disease presentation. We see it specifically in some clinics, but we also see it significantly impacting different parts of the system at different times. So across primary and community care, we see, we hear from GPs the number of people coming to GP practices and in primary care, and housing related exacerbations is a significant reason for their presentation in a clinical setting, across social care, across mental health, across the ambulance service and across acute care. And we can just see some of the other examples, again linked to climate action. We can see how extreme heat and cold are impacting differently, and we've definitely seen in the last few days the number of people presenting in both primary care and acute care with exacerbation of their symptoms because their home is significantly overheating. And the scale of the challenge, and to quote, I think Ian Holmes there in the chat, should be met by the scale of ambition that we have around that, and you'll see in the appendices there's a range of options. Now that's not necessarily designed to be looked at there, but in terms of what we can do in building in health, there's significant things that we can do in the way that we build new homes, but also in the way that we retrofit homes. That there's plenty that we can do, and the Housing and Regen Committee are particularly interested in taking on that challenge. But then there's a lot more that we can do in terms of prevention, linking our data sets. It was one GP who said to me, I'm really blind when it comes to the housing system. I can't see any of that on my system. And similarly, our housing colleagues, and particularly those in local authority housing options teams, will say, they can't see anything about somebody's health, and they have to do an awful lot of digging when people present to them with medical issues and challenges. And they also say, they're really struggling to prioritise those people. So some people will present to housing options team talking about unwellness and feelings of unwellness, and it's very hard for them to prioritise the impact on somebody's health based on the risk of their home. So there's a lot more we can do around that data sharing, smart risk mapping. But also in terms of interventions, what we hear time and time again is actually what we need to do is have that combination of the human advice, the human person to person. So some of those people that spoke to Health Watch have been on a peer-to-peer housing support challenge, and that's been people who've they themselves have been learning about how to maintain a healthy home. What are the things that people can do at home and in their environment to keep the air quality improved, particularly around those with respiratory illnesses. What are the practical things that you can do in your home? And that very much needs to be done human to human. But then there's an awful lot more we can do with sensors and tech. The university has got the university has got a thing called the Healthy Building Network, and that's multidisciplinary, and it's got loads of options and lots of opportunities. And particularly when we look at AWAB's law coming into force, the first tranche of it coming in this autumn, we can see the opportunity where we can match that early intervention. If we can actually match the health predictive health analysis of where ill health will happen because of housing, we can actually then really target those homes for those interventions that will help mitigate, because for all the reasons mentioned above, the availability of homes is not going to be there, that we will be able to rehouse everybody who's currently in a poor home. We will have to invest in mitigations, and if we can target those effectively, then we're really doing well. And then lastly, that requirement for specialist homes and supported living, it's absolutely there, and we can see that across our system. There's lots of people who are in our health and care system and staying for unnecessarily long times in our health and care venues who don't need to. But we do not have the right availability of supported living and supported homes to put them into. So that's just a really quick canter through a massive amount of information, and each of those sections could have their own subsection in terms of what we'd like to talk about. But we wanted to bring this single conversation to both forums to really ask what's the scale of ambition that we want to have in West Yorkshire about bringing the key agendas together. What are the things that we think we can most scale up to match that scale of the challenge, and what other areas do we think, what other opportunities are there for doing any of this? I don't know if Jen wants to add anything, but I can see Mayor Brobin's hand up, and I know there'll be lots to speak about from her point of view.
Thank you, Rachel. You've done a really good job of summarising all that evidence. And I think just to note, thanks to you and to Carl for pulling all of that together, from the Combined Authority for pulling that together and bringing it to both audiences at the same time, so we can have this really sensible debate. I think being able to summarise the evidence, as you've done in one of the appendices, highlight all the work that's going, do that mapping of the work that's going on across the patch, and then be able to bring this conversation to the fore. We know there are challenges in terms of the resources and some of the levers available to us to actually take on some of these opportunities, but really welcome people's thoughts on the kind of principles of discussion that you've outlined in the paper. Thank you.
Thank you both. Tracy.
Just wanted to add my thoughts and congratulations for bringing such a brilliant report to this forum, but also to the Housing in Place Forum. The two have to be aligned, and it's so interesting in the report where it says housing can no longer be viewed as a social issue when all the evidence shows it represents a large and growing clinical burden in the NHS. And it's not referenced in the 10-year plan how mayors or local leaders can support the NHS by focusing on housing. As some of you may know, here in West Yorkshire, we have made housing a priority, particularly affordable and social homes. And we've delivered more affordable homes in the last 2 years than any time since the economic crash. I grew up in social housing. I know the impact that had on my life, and I want that opportunity for everybody in West Yorkshire, and certainly it will also improve health outcomes. And there are a number of things that we're doing. We're working really hard with Homes England and our housing association partners, how we escalate our ambitions around affordable and social homes. You'll have seen the government wanting a massive uplift in social homes across the next 5-10 years, and where we stand ready to help deliver that. With 85,000 people on the waiting list, it couldn't come soon enough, quite frankly. Now, it's also not just about in the here and now, but also for the future, which is why I'm pleased that in West Yorkshire we've got our Dementia Ready Task Force with recommendations for house builders how you build those new homes that are ready for a lifetime. And it is really shocking when it comes to accessibility that it's almost 50-50 how many homes are built that have wheelchair accessibility or width of doorways for the need. Only 1% of the housing stock, 2% of the population use a wheelchair. So there's something really wrong there when it comes to equity, and something that we should be tackling. But also I was really pleased to bring the Minister, Miata, up to West Yorkshire just last week and show her the work we're doing on retrofit. And we're on target to deliver 10,000 retrofit homes. I mean, goodness me, we have 180,000 to deliver. So it's incremental steps. But speaking to Julie, whose home it was, about disruption and would she advocate for it? She was so thrilled with what the retrofit has done for her. Not only is it warmer, her bills are lower, but also one of the side effects of insulation is that it's quieter. And she certainly was on one of the estates in Bradford, plagued by motorbikes and antisocial behaviour. She said it's really helped her well-being, the fact that it's quieter because of the better windows and the thicker walls. And she's now advocating for others in the community to take that up. So I believe that it's not just about building affordable social homes. It's also AWAB's law, widening that out not just to social and affordable, but to rental, private rental as well. No child should live in a mouldy or damp home. Nobody should. And particularly those recordings were very powerful about leaks and fear of the ceiling collapsing, rats, mice. This is Victorian. The challenge is when in Calderdale we have the highest number of homes predating 1919 than anywhere else in the country. We have a job of work to do. But I just wanted to say that this is a perfect example of how the partnership working can deliver better outcomes, because absolutely doctors should know about people's housing circumstances, but also housing associations and landlords should also know about their tenants' health challenges as well. So this is a brilliant place to share this sort of data, and also to find solutions of how we can work together to deliver faster, but also to tackle the challenges of the here and now. But thank you very much, Rachel and Jen. I know you've done an amazing job getting this together. It's a very powerful paper and definitely worth sharing more widely. Thank you.
Thank you, Tracy. Sarah?
Yeah, thank you, and thank you, Rachel, for sharing this. And I think there's some real key points in this, and just to pick up some of the great work that's been led by the Health and Housing Network in West Yorkshire, which has been up and running for about 5 years, chaired by Sarah Roxby, who works for Vico now, was at Wakefield District Housing as our sort of health and housing lead, and supported by a lady called Leanne, who works for Vico as well. And I just wanted to flag this up because I think there's some real kind of key opportunities you flagged in the paper. But just to give a flavour of the kind of work that can be done when housing and health colleagues start to work together. So I think on housing as a determinant of health, there's some great work going on in Leeds at the moment, led by the whole city, but through the Marmot work, Professor Michael Marmot. And one of the two key themes they're looking at in Leeds through the public health team is housing as a determinant of health. So there's some excellent work happening there and some really exciting work happening there. I think you flagged up, Rachel, in your presentation, homelessness as a sort of health determinant of health, and particularly the health needs of rough sleepers. So from our sort of population health perspective, that's a really key group from an inclusion health perspective that we're focusing on. And again, a really interesting pilot that we'll hope to share some outcomes from soon around earlier diagnosis for respiratory health conditions in the homeless population who often go undiagnosed. We don't pick up till later on, and then that leads to poor outcomes for them and significant health and care burdens. So there's some outreach work we've commissioned through the Inclusion Health Unit to do some earlier diagnosis there. And from a health and care pathway point of view, I think there's some really exciting work we can explore more about that has been led through some work at in Pinderfields at Mid Yorks Hospital Trust, looking at discharge pathways. It's been really well evaluated. So where housing is a barrier to discharge from hospital, that's not only kind of a service issue, but an issue on an individual and a patient level as well. They've got some housing discharge coordinators there. So where housing is a barrier to discharge, they've done some really good practical work there to support discharge. So I think there's so many risks, isn't there, and so many opportunities. And I think you've flagged up, Rachel, that this is a rising risk as well. But I think we've got some really good examples of work we've done in West Yorkshire where we've come together and kind of looked at housing as a determinant of health and made some really good progress as well. Thank you.
Thank you. Fatima.
So really helpful that I went after Sarah Smith, because she is often the yin to my yang. Firstly, I completely agree. I think Maria and Sarah Roxby and Leanne have all done some incredible leadership of joining up the VCSE sector, the housing sector, local government and health to deliver some really powerful and inclusive outcomes. I suppose my question is a few reflections. One is there is so much we could do, but we do need to prioritise, because we can't do everything. And just in light of the changes that are happening within the health and care system and our partnership priorities, is there an opportunity for the board to put its strategic leadership behind this as a priority? Because I think there is more that we could do. It was a real privilege to attend the Marmot 2 years on launch, and there were some really great examples of not only the work in housing, but regeneration and equity, and really ensuring that we address other elements beyond housing, but using housing as an opportunity to address some of the challenges in inequality, but also the wider determinants of health. We're doing loads of work on, health and wealth, for example, that Tracy's mentioned and Rob's mentioned, but also places where people can convene and access support for other things as well. And I suppose the other bit, when we were discussing this within the committee a couple of weeks ago, one of my sort of challenges to them, and the Mayor alluded to this, was we're doing some great work with the Dementia Task Force, but how do we create a sustainable housing model that is fit for the future? So as more and more people will have changes in circumstances, will need adaptations and further needs, how do we create something that is fit for purpose for the future, as well as amending our current housing stock? And I think there's an opportunity for us as a board to provide some strategic leadership. I volunteered in the committee, and I'm reiterating my volunteering here, to join some of these dots together and to do a couple of things really, really well at scale and at pace, because some of those stories of people living with rats, to me, is unacceptable in a 21st century prosperous region. But again, it's with the caveat of resource and prioritisation to deliver outcomes that benefit some of the most, overlooked people within society right here, right now.
Thank you. Rob?
Yeah, so just add my thanks to everyone for the work that goes on in this space, which there was a national event recently and they were talking about housing and health, using the word.
Can't quite hear you, Rob. Can't quite hear you, lovely.
Sorry, do you want to take Nadra, and I'll try and sort my mic out.
Okay.
Okay, thank you.
Okay,
thank you. This is thanks. Thank you, Councillor Swift. This has been another absolutely impressive and fantastic presentation, and really sort of helps us hone into what it's like living in and working in West Yorkshire and how this affects our health. I think one of the pieces that I think is slightly missing, and it occurred to me when I was listening to the voices, people's lived experiences, and that's about the role of education and the impact of education on young people living in housing that we've talked about. I mean, I was doing some work recently with Born in Bradford and Child of the North, and John Wright was asked, what is the one thing we could change that would really make a long-term difference to young people in our region? And he said housing, better housing. So housing really is fundamental. But I think if we could put that piece in about the impact of education outcomes due to poor housing, it would really amplify and make bigger and better the rationale for really doing something different and quickly around housing. Fabulous presentation. Thank you.
Thank you, Nadra. Kate, then I'll come back to Rob.
Did you call my name, Tim?
Yes, I did. Sorry.
Yes, sorry. It's okay. Thanks very much. I think it's very encouraging to know that we are doing something about housing. It's a long time waiting. Basically, we in primary care know that we get patients coming in with respiratory infections so frequently, and especially people who are living in this poor housing are the ones which are suffering the most. And I think we need to to appreciate all the investment being done in this. Determinants of health. There's so many determinants of health. To be honest with you, we should be looking at all the determinants of health. We should all be making progress on all of them. I think job opportunities and having a good job is a huge determinant of health, and having a good place of work and a better environment at work is a good determinant of mental health. We had Phil from Council last week, and he was talking about accelerated funding for getting people back to work, and they are doing a lot of work. And I think we need to look at how some of these works can work in tandem with each other to see we can look at common improvements in all of these areas. Working with employers, working with housing, working with the social services together, and that's where I think our collaborative work is needing to be more important. Neighborhood working, wonderful. We as primary care have been delivering neighborhood health for since its inception. We are working in the neighborhoods. We are sitting in there and delivering it, and who would know better than us to deliver on neighborhoods? We want social services to be working with us. We want local councils to be working with us. One of the things which touched really was that lady who was talking about police not listening to them. And I think that is something which really I've heard so many stories from people, from patients, that police, is not interested in what their problems are, and I think that need a serious thought. And I think I would ask Tracy to seriously look into some of these things where we can get people to feel safe in the communities, and I think that's something which needs to be a priority, especially for people who are at the margins of the society, who we don't focus on much. Thank you.
Thank you very much. I'll bring Vicky in and then come back to Rob, and then I feel we probably need to move on or we'll start losing people. Vicky.
Thank you. And it's not just specifically about this housing paper. I think it links to all the papers that we've had. That there's something in this about our roles, and I'm talking about the ICB's role here, our roles as strategic commissioners. And there's a theme coming through about how we make sure we get some key elements and key principles into all service specifications moving forward, regardless of who's doing the commissioning and the planning of those. And I think specifically for housing, it's about how we can factor that in so it gets picked up early in the actual planning applications as well. So it's back to some of those key elements about what are our aims, whether it's in relation to children and dealing with the damp, etc. But also, I think it was Rob mentioned dementia, and that some of the environments that we need to be able to support and sustain people in their own homes moving forward, especially where we know it's a growing need. And if we can get some of those principles into the planning guidance, what we're doing is we're changing that culture of the people that build the homes on behalf of the populations as well. So I think it's a slight change in mindset to that, I'm going to say, strategic commissioning role that we need to do across the border partnership, not necessarily that we're in there with absolutely everything.
Thank you. Rob?
Yeah, so hopefully that works now. Yeah, great stuff, thank you. I think this it's been a great conversation, and really some fantastic work in the system, which is highlighted, and also opportunities for us to go further. As the partnership develops and as we change the structures and think about what we're doing here in West Yorkshire, it seems to me that there's some choices that we need to make about where we prioritise. And this is a really strong case for saying we've got to do housing and health work together at a strategic level. As the Mayor said, housing is a health issue, and it does have an impact upon clinical issues as well as utilisation of services. So we know that women with children in cold damp houses call the ambulance more, and their children get conveyed more to hospital. So we've a huge amount of work that we could do together. So as we just develop the new West Yorkshire arrangements with the Mayor and the office there and the ICB, let's be clear about which big ticket strategic issues we're going to deal with. It seems to me that we should agree that this is one of them.
Thanks very much, Rob. That's a really helpful steer and sense of direction, I think, in pulling together the work and the conversation we've just had. Rachel and Jen, thank you so much for the work that's gone into this paper. It's prompted a lot of discussion, and I think it will prompt a lot of work going forward as well. So thank you very much. The Mayor's West Yorkshire Local Transport Plan consultation. Tracy, are you kicking this one off or passing on to
I'll kick this off and I'll keep it short because I know we're behind time. But this absolutely chimes with Khalid's point about the wider determinants of well-being and health and opportunity. And it links to housing, but also transport and feeling safe. As you said, Khalid, that we have our 15 PCSOs on buses and in bus stations, which was new. We hadn't had those before, paid for by our levy share scheme by Asda and Morrison, so thanks to them. But it's a really important pivotal moment for us because we launched our Weaver network, which is our integrated transport plan. We know our bus network doesn't work. We know that we have two of the biggest cities in the north, Leeds and Bradford, connected 8 miles apart and connected by a really poor service and also far too busy roads, bumper to bumper cars trying to get between Leeds and Bradford. A tram would absolutely open up that opportunity. We're really pleased we got the 2.1 billion from the Chancellor to get us underway with spades in the ground by 2028. So we've got our buses that we're bringing back into public control, our tram that we have the money for, the rail part of West Yorkshire, whether that's Leeds to Ilkley or the 5 towns, we're going to bring that into the Weaver network. And we've been working with other mayors in Yorkshire with Lord Blunkett to identify our pitch to government about investment in rail for our region. And then, of course, active travel, which is a real game changer for health outcomes. So that's the electric bikes you may see in Leeds that we're hoping to roll out towards Bradford and then again towards Huddersfield, where we've got student populations who might really appreciate electric bikes. But this is the whole integrated transport plan. Now, it's just gone out to consultation, and I really would be so grateful if you would take the time to feed in your thoughts about the Weaver network and the transport plan. And I really hope that you see that the name and that simplicity of the name also gives you an indication of what I'm hoping to achieve, that we weave in and out of communities, stitching communities together, and having that patchwork of communities brought into that cohesive whole. It also speaks to our heritage. We all know our weaving and textile heritage, but also the fact we speak across West Yorkshire 170 different languages. So bringing people together to say, you know, this network is for you. And I just hope that you can help us and be advocates and ambassadors for it in all of your conversations, because the only way we can grow our economy and get more money in people's pockets is to give them the access to jobs, opportunities, doctors' appointments, hospitals, nights out, parks and leisure facilities. It's a real turning point for our region. So do please have a read of the paper and also get involved in our consultation. Thank you so much, Chair.
Thank you very much, Tracy. So this is very much a request for us to promote the consultation and, of course, to feed positively back into it. And as you say, it's absolutely critical for health in all sorts of ways. It's a favourite little word of mine that, you know, when I was working for Age Concern and you consulted older people about health, you always ended up talking about transport. And there's a really good reason why that happens, because it's such a challenge getting access. So I don't know if anybody wants to add anything to that. And if you want to find some more parallel words around weaving to use to support it, come and visit Calderdale Industrial Museum, Tracy. I'll give you a tour around and we can find a few more terms you can throw in as well. But no, brilliant. That's great. Thank you so much. Okay, so final item is integrated care partnership governance. I'll ask Laura to bring this in. I should just say, you know, sorry we put this on the end of the agenda. Governance is really important and really interesting. Actually, governance should never be interesting, because when it becomes interesting, it's too late to get it right. So, Laura, over to you.
Thank you. Yes, I'll just briefly introduce. So for those who don't know me, my name's Laura Ellis. I'm the ICB's Director of Corporate Affairs. I'll briefly introduce both documents together because they sit alongside each other. So the Memorandum of Understanding that you've got is a document that we put together a number of years ago and was designed to formalise the ways in which the partnership works, and it describes how we organise ourselves and makes that commitment to providing the best health and care that we can and serving our population. It's not a legal contract. It's not sort of got legal base. It is a formal understanding between the partners of the partnership. It hasn't been reviewed for quite some time. We had originally planned a wider scope of review. However, given the changes within the NHS, including the 10-year plans, focus on the future of ICPs, we focused instead on just essential updates that we think we need to make as an interim, so that the document is fit for purpose. I think given the timescales of the potential future change as well, it does make sense for us to do that now, because we are certainly a number of months away from anything different. All the changes are marked with tracking to try and make it easier to see them. I think at first glance it can look like there's quite a lot of change, but actually they're often the same thing repeated throughout the document, and they are fairly minor in terms of what they are. They're really largely about being accurate within the document. We will just be updating the signature page at the end to reflect all of those partners that are listed at 1.1 within the document. It was pointed out to me that we've missed a couple in translation between the partners at 1.1 and the end. So apologies to the Combined Authority, because I know that we'd missed you off. So we'll sort that out before we send the document. We are looking for the board's approval in principle, and then we'll be asking partners to take through their respective governance arrangements, and my team will liaise with your governance colleagues in each of the partner organisations. Just quickly in terms of the terms of reference, so this one, terms of reference have been reviewed as part of the end of year governance review that we've done, and thank you to everybody who came back to us on the effectiveness survey that we did during March and April. We've got some really valuable feedback from the survey, and we've worked through that and made some proposed changes to the terms of reference. Again, they're within the context of the changing landscape, but it is also some time since they were reviewed, so we want to make sure that we make sure they're accurate for you. Changes are again in with tracking. I think what we have sought to do is a few sort of what I would call good governance updates. So added some bits in that you would normally see in the terms of reference. And then we've also made sure we've clarified around membership. So that was one of the things that cropped up through the end of year survey. So we just made sure we've clarified that section. So as opposed to the MOU, which is signed by all partners, the terms of reference are authorised. So this is a statutory joint committee between the ICB and the local authorities. So they're the partners who sign up to the creation of the joint committee, and therefore its terms of reference. So again, we're looking for approval in principle this afternoon, and then we will take through the respective partners for authorising the changes to the terms of reference. That was very swift introduction. If there's anything that you want me to go back or to talk about in more detail, happy to do that.
No, thank you. That was a good, clear summary, though, and clarified the point about the mayor and the combined authority. So thank you for that. Fatima.
Thank you, Chair. Laura, you know I love a bit of governance. Just a couple of reflections. Really thankful that you've picked up already the WICA bit, because I was going to bring that up. A couple of questions regarding 3.4. So there's reference to the importance of diversity, which is really great to see. I do think it is quite dated considering the work we've done on equity and fairness, and maybe we need to update the terminology and also the networks referred to within the document, and I'm happy to pick that up and work through with you on that. Regarding 3.4 and involving the public, I was just really mindful of some of the discussions we've had previously during this meeting about the abolition of Health Watch and the new ways of working, whether they are sufficient or not. And just to sort of query the sort of forums that we've got in there. So we talked about non-executive members, we've talked about patient reference groups, etc. But just being mindful of some of the inequalities that have already been highlighted about those structures, I just wondered whether there was more we could do in that space. But apart from that, happy to support in principle with those changes.
Okay, any more? Laura, is that something we can...
Yeah, absolutely. Thank you. If there's some accuracy changes, let's make those now. If there's things that we want to look at as we're doing a bigger review in the coming months, then that'd be really helpful. I'll liaise with you outside of the meeting. Fatima, thank you.
Thank you. Ian?
Yeah, thanks, Laura, and thanks, Sue, for the work on this as well. I think it's kind of helpful that we've got something that's clean and up to date for now. I guess a couple of obvious points, really. Firstly, we will need to look at this as we move into the kind of the medium term in relation to the changes that are happening. I think we've all spoken about the importance of having forums like this to work collectively, but thinking carefully about what that looks like and how it operates is going to be important. And secondly, linked to that, I think in the next few meetings we'll look to put in more private briefing sessions with members so we can have a little bit more of a open conversation around the specific implications of the changes. So we'll look to do that as well. But I'm really supportive of the amendments that you've suggested, Laura and Sue. So thanks for that.
Thank you. Rob?
Yeah, so thank you, Laura, for the work. I think the question for us really is that will this do for the transition period in terms of the MOU and the terms of reference? And I think the answer is yes. I just wondered, Laura, do we need to strengthen at all in the terms of reference the relationship that was set out in the governance chart and the briefing that we did for the ICB? Where this, there should be a relationship between the Transformation Partnership Board and this bit of the system and the work that we do, which would help to make sure that that transition was managed appropriately. That was the only comment I had on reflection.
Okay.
Yeah, thanks. I'll have a look at that.
So if people are happy then to approve them in principle, subject to any sort of minor editing, and for me to sign that off as chair, that would be very helpful. That's brilliant. Thank you so much. And thank you to Tracy and Laura for dealing with those last items so efficiently, because we've got back on track and still finished within the available time. And not only did I get in a plug for the Industrial Museum, but somebody else has joined in the chat and said how brilliant it is. So, yeah, so please come across to Calderdale and visit, because it's a volunteer run. Yeah, OK, I'll stop pushing my luck now. I should probably declare an interest, shouldn't I? Yeah, thank you so much, everybody. I think that's been a really valuable meeting. I hope people have found it valuable, but we seem to have covered an incredible amount of topics and issues. So thank you to everybody for your contributions, and thank you to everyone who's worked so hard behind the scenes getting the papers together and making this happen, because I know how much work is involved in these meetings. Not allowing any other, assuming there isn't any other business. So I'd just like to say thank you again to everybody. We'll be meeting in November next, and that's due to be in person. Of course, if things change dramatically, we may have some sort of informal sessions in between. So thank you all for your time.
Thank you, Chair. Thanks, folks.
Thank you.
Thanks, everyone.